Hello, everyone, and thanks for joining us for Depression Screening Innovation Challenge results. My name is Mary Mucko. I'm a specialist on the Provider Outreach and Education team at WPS Government Health Administrators, also known as WPS GHA. I will be your host today. Also here to share some information with you is our Contractor Medical Director, or CMD, Dr. Joelle Vlahakis. My friend and colleague, Ellen Barra, will provide technical assistance. We include this disclaimer in all our education to remind learners that although we made every effort to provide current information that is correct, the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws and regulations and rulings will always prevail. We will provide responses to questions based on the facts given. And lastly, just a reminder that CMS prohibits recording of this presentation for profit-making purposes. Late last year, WPS GHA wrapped up a CMS Innovation Challenge. We want to share results with you and thank those providers who walked alongside us on our journey. While the project was a huge success and one with outcomes we are proud of, as Dr. Vlahakis has stated, we haven't cracked the code. There is still much we can do. Based on what we advertised and on the webinar description when you registered, during today's webinar, we will be discussing an overview of the project. We'll talk about key performance indicator goals, outcomes, and program return on investment. And finally, we'll share some helpful resources with you. Now is the ideal time to provide results to our partners and provider community because it actually takes time to adjudicate our claims data. Although our final report to CMS for our project was due October 15th of last year, we continue to monitor claims to observe what are the true results. In other words, although our project initiatives ceased, claims do continue to be submitted and processed for this very valuable benefit. We are confident that based on the efforts of WPS GHA and our provider community who helped us spread the word, more and more providers will continue to render and bill for depression screening, far beyond the end of the innovation project period. So let's begin then with a project overview. On November 14th of 2019, the Centers for Medicare and Medicaid Services issued a challenge to Medicare administrative contractors to identify underserved populations and underutilized services in their respective jurisdictions and to propose a plan to remedy this underutilization. So because depression is an underrecognized chronic disease to society, WPS investigated this condition as a potential response to previous challenges that were issued by CMS. CMS accepted our proposals in 2020 and again in 2021, and for the 2023 innovation project, as displayed here on this slide, WPS submitted two proposals, one for the continuation of depression screening initiatives and one for chronic care management education. Both were accepted by CMS for the 2022 project year. So this slide then shows that a total of 19 proposals were submitted by the Combined Medicare Administrative Contractors, or MACs. 6 proposals were selected, 2 of which were submitted by WPS. And as the title on this slide says, it was an honor to be chosen. The project year 2022 ran from September 1 of 2022 through August 31 of 2023. While chronic care management was new on our radar, this project year was actually the third year to focus our efforts to meet proposed goals for depression screening. The difference between years 1 and 2 was the emphasis on health equity. Although our proposal included a vast array of resources, the Area Deprivation Index proved to be one of the most powerful and far-reaching. We used the Area Deprivation Index, or ADI, as a surrogate marker to help us identify areas where the social drivers of health may be negatively impacting our Medicare beneficiaries. The ADI is actually based on a measure created by Health Resources and Services Administration over 3 decades ago. It has since been refined, adapted, and validated to the census block group neighborhood level by Amy Kind, MD, PhD, and her research team at the University of Wisconsin in nearby Madison. It allows for rankings of neighborhoods by socioeconomic disadvantage in a region of interest, for example, at the state or national or even county levels. It can be used to inform health delivery and policy, especially for the most disadvantaged neighborhood groups. It includes factors of neighborhoods by socioeconomic disadvantage in a particular region of interest. It factors in theoretical domains of income, education, employment, and housing quality, for example. A neighborhood is defined as a census block group. So these are goals in the proposal that we submitted to CMS for the third year depression screening project. In our MAC jurisdictions, we propose to increase the use of this valuable benefit by 5%, to increase the use of depression screening by 2.5% in those particular areas with ADI greater than the 70th percentile. And finally, our goal was to decrease suicide attempts by 5%, or those claims we received that indicated suicide attempt on them. My slides are out of order, so I'm going to move back here, and I apologize for that. These are our project team members, and although our lofty goals would be based on contributions by the entire MAC staff, a project team was appointed to be responsible for executing the tasks and producing outcomes that were outlined in that project plan and schedule. And as excited as we were to use tried and true methods of reaching our goals like we had in the past, we knew that we had to be ready to do things differently in this third year. Dr. Joelle Vlahakis was brought on board by WPS with the sole purpose of leading this project. Pragati Singh, a population health specialist, was hired by WPS as a consultant. She remained in her position at NTT, which really kept her external to WPS, and that was indeed by design. Both Dr. Vlahakis and Pragati assumed positions created by WPS expressly for this project. And this had two advantages. These were literally their only jobs, and they had no preconceived notion of how things had been done previously. In Dr. Vlahakis' words, because we had a team who was willing to put up with that occasional discomfort that new colleagues can produce, it really worked. That back and forth between all of us fueled creativity and forward movement. Ellen Barra and I, both longtime provider outreach and education specialists, joined the project team, and portions of our workload were dedicated only to the Innovation Challenge projects, while Ellen's workload was dedicated mostly to the Chronic Care Management Project. 40% of my time was earmarked for depression screening, and both Ellen and I worked as a team to develop and share education on both of the challenge topics. Other instrumental dedicated project team members were Matt Davis and Abby Wolf. Matt is the manager of our Insight Data and Analytics team, and Abby is a senior healthcare informatics analyst. This slide summarizes how we propose to accomplish our goals. We would focus on those providers with a high number of at-risk patients. We also use data to focus on those providers with patients with social risk factors a couple of which are socioeconomic status and geographic distance to the provider. Our data analytics team helped us identify the populations at risk. The project team would seek out innovative ways to tailor the approach used to increase depression screening for that population of risk. At risk. And finally, we proposed to build on those successes in project years 1 and 2. This slide includes the key initiatives employed in years 1 and 2, which were both successful. First was collaboration and partnerships. This included partnerships with external entities to facilitate the dissemination of information that would help us assist in reaching our project goals. Now, this included, just as some examples and shown here on this slide, our state medical societies, our contractor advisory committees, and these consist of a group of physicians across all specialties who assist WPS-GHA in the creation of local policy, and also partnerships with other organizations. The items shown under our second key initiative there in the second column here, this shows methods that we employed for outreach and education. You can see some examples there. Our portal, our YouTube channel, we did some educational mailings. We asked our provider outreach and education advisory groups to help us get the word out. And also, we employed teleconferences, webinars, and seminars to get this information out to those providers who needed it. The last key initiative involved was data and analytics, and I mentioned to you that Matt and Abby were our team members. Our insight staff was instrumental in providing the data that we used for comparative billing reports, analysis, and surveys. So, what changed in year 3? What kind of innovative pivot points were provided useful? We greatly expanded external collaboration and partnerships, and with the help of our new WPS project team members, both Dr. Vlahakis and Pragati, our education expanded to include collaboration with new or underrepresented groups. Dr. Vlahakis arranged roundtables with experienced physicians who shared a wealth of experience and knowledge. Dr. Vlahakis and Pragati used innovative ways to reach out to those non-traditional partners who were in a position to share our education with others. And so very important was that we listened to each other. As mentioned, we dedicated full-time staff. We added new staff to deliver the outreach and education. And this enabled us to provide over 40 webinar hours to about 1,700 learners. The dedicated staff significantly increased our virtual education with over 600 views and use of digital media. Other education included the addition of Dr. Vlahakis' blog. It's known as Medicare Buzz, and you can find a link to the blog on our quick links. It's located on the right center of our homepage. I'm going to show you that just for a moment because I think it's information that you don't want to miss. So if you go to the WPS webpage, and I'm going to get there eventually. Let's go this way. I apologize. I had it ready and I should have grabbed it. If you go to the home page on our website, I'm going to make this a little bit bigger here. On the right center side of the page, you will find quick links. Here is where you can find the quick link to the Medicare Buzz blog. I'll show you what it looks like here. Some great additions made here by our very own Dr. Vlahakis. So if you get a chance, take a look at these and pass that information on to others that might not know that we do have this blog that exists. Now it is my pleasure to introduce my friend and WPS-GHA Contractor Medical Director, Dr. Joelle Vlahakis. She will share results of the Innovation Challenge with you. Dr. V, take it away.
Okay, can everyone hear me all right? So I love hearing Mary talk about this because it's been a little bit of time since we've had an opportunity to work together, and we just had such an interesting, wonderful year. It was very challenging, and I am so excited that we have really positive results to share with you. I will tell you that when I came on board, one of the concerns we all had was that, this was the third year of our work on this particular project, and we weren't sure we could get much better. The first two years were amazing. This team before me had already really done tremendous work. So we were hopeful, but still cautiously hopeful that we could continue to demonstrate success. And I will tell you that the fuel in the engine for this project is definitely our provider outreach and education team. They partnered with many of the people on this call to make sure that the message continued to be received on the other side. It did us so much good to start to see some real interesting work being done by our partners, things that we wouldn't have thought of, things that we could then pass on to others. So we had, as we mentioned, our goals stated. We were hoping that we might be able to increase the number of claims for our depression screening by about 5%. Well, ladies and gentlemen, you really knocked it out of the park. We were able to increase in our 4 states that make up J5, increased by 37% higher than we had anticipated. That means that there were people out there who got screened for depression that wouldn't have the year before. In addition, we had the more modest goal of trying to increase depression screening claims for our more disadvantaged beneficiaries. Don't forget, Medicare beneficiaries live everywhere, and they live in all kinds of different places, rural, urban, and the like. And we were trying to figure out ways to get into those patient and provider encounters. And we thought, this is a new sphere for us. Let's see what we can do. Let's see if we can increase it by 2.5%. Well, we were able, because of the work of our partners, to increase it by 27%. That means, again, that the folks who probably need it the most are getting screened for depression. And then, most importantly, we were hoping that this effort might actually have a considerable return on investment in that we would see fewer suicide attempt claims. Now, obviously, this is not a perfect measure. We hope that our assumption that it's a surrogate marker for fewer people who lost their lives to suicide is correct, but we were hoping to diminish it by 5%, and we were able to diminish it by 9%. And those are people to us. I know it's a curve and it's a very pretty curve, but for us, what motivated us was that we knew that there were people on the other end. And again, this is work that you and your providers did. Next slide, please. All right. So, one of our questions was, all right, so we had, these great results, but maybe depression screening is increasing on all fronts. How do we look compared to other jurisdictions or other regions? How are their changing claims? Well, I think you can see rather handedly that when you consider what is being done in other regions, that the efforts that were made by WPS and specifically by our provider outreach and education team really seem to make the difference. We had a incredible percent in claims compared to other MACs. I think the numbers speak for themselves, but we were especially delighted in claims among beneficiaries that lived in areas with a high area deprivation index. Next slide, please. And then, of course, of interest to all of us because we are residents and citizens, um, is our concern for the Medicare Trust Fund. Did we steward this appropriately? One of the things that we try to emphasize with our providers um, is that they can be paid for this depression screening. And that is really essential because we want them to be reimbursed for their work appropriately. We think that's essential and important to making a difference for our beneficiaries. But it's awfully nice to see that, in point of fact, when we look at the cost of these programs, particularly depression screening, what we find is over time, maybe not initially, but over time, what we see is that each of our beneficiaries, when they're screened and presumably treated for depression appropriately, that their amount of costs per beneficiary for their care diminishes. And if you talk to most providers, this makes sense to them. If we treat depression well, very often other chronic illnesses follow. Next slide, please. All right, so how about our other jurisdiction, J8? That's Indiana and Michigan. How did we do there? And again, we knew we had had some success already in this particular region, and we weren't sure if we could continue to promulgate that in another year. But I can share with you that we were delighted that we were able to succeed here. We were able to increase depression screening claims by over 42% compared to our first year that we started measuring. We also were able to increase depression screening again, likely for those beneficiaries who need it the most, by about 32%. Now, we were hoping to reduce suicide attempt claims by 5%, and we fell a little shy of that. We only diminished it by 3%. But I wanted to share with you that although it was perhaps the only disappointment we had in the overall project, when I looked at it, the overall number really made what we did was potentially save 34 fewer claims for suicide attempts. That's 34 people, 34 families. So although we didn't quite meet the mark, we still did an extraordinary job in this market. And that is, again, thanks to the end work that's done on the provider and patient level, which many of you can take credit for. Next slide. So again, we wanted to ask that critical question. Okay, so what? Did we really do it? Did the work that we performed, did it make a difference, especially compared to other regions? And indeed, it looks like we found something. We found some key behaviors, some key opportunities that seem to make a big difference in this jurisdiction. Next slide, please. And then, of course, we like to see, are we stewarding that Medicare trust fund appropriately? Does it look like we actually have a cost savings when we take a peek at those numbers? And indeed, in addition to that, we take a look at suicide claims attempts, and it does look like indeed all other jurisdictions saw a slight raise, and we in J8 saw an almost 20% diminishment. Next slide, please. All right. Again, because we are in charge or, trying to steward claims and steward our Medicare trust fund, we wanted to take a look at our return on investment. CMS trusted us with this innovation project. They said, yes, we'd like to fund it, but we wanted to know, did we do our part? And indeed, when we look over the 3 years of the overall depression screening efforts, what we found was a total of about $53 million in cost savings. And that's not a small thing at all. We've calculated it out based on per beneficiary. But I think what we all understand to our bones is that when we start to treat our folks for depression, we actually make an impact in a global way. Next slide. And I'll stop here and hand it over to Mary. Mary, thank you so much for letting me participate.
Thanks for joining us and for sharing that great information. Next, I want to talk about just a couple of the resources that we developed during our project, those that I think would be helpful for those of you who may still be seeking some education on depression screening. This slide lists some of the many resources that we tweaked or created, revised during the third year of the Depression Screening Innovation Challenge project. We have available on our website a depression screening fact sheet, which is pretty much soup to nuts. Anything you can wonder or ask about providing the depression screening and receiving reimbursement for it from Medicare. There's also a depression screening training webpage available on our website. And finally, something that you may or may not be aware of, we have a depression screening playlist available. And I'm going to show you what that looks like here. We have on the WPS YouTube channel, and that information is included on one of the slides here, or you can simply go to YouTube and on the internet, go to YouTube and then search for WPS GHA. You will find our channel there, as well as in places, links available on our website. But here are the many playlists that we currently have available. There's quite a few of them. And one of them is indeed dedicated solely to depression screening. It's right here. So if you choose to view the full playlist, you will see just a number of YouTube videos that we created, throughout the challenge project time period. So quite a bit ago. There may be a couple of them that were out there from the challenge years 1 and 2, but most of these, as you can see, were created about a year ago. That means they were created within the third year of our depression screening challenge project. So if you're not aware that these exist, or even any of the other resources or playlist titles, this might be very, very helpful to you and to those within your organizations. All right, this now brings us to some time for questions. And while you're placing your questions into the chat, I do want to show some information that's available out on the WPS GHA website, something that we're talking about a lot. And just a reminder to all of you that on the homepage of our website, right here in the center, is a revolving message. Sometimes we refer to this as the carousel. Some of the information that's out there right now is on the Change Healthcare security incident. And if you choose to read it, it will tell you about this cyber attack. And it will tell you it's not a CMS or WPS incident, but CMS wants you to know that there are options for those providers that submit Medicare claims to WPS, including some accelerated and advanced payments relative to the cyber attack. So I just wanted to point that out, that information is available to any of you looking for it. Just check out the revolving messages on our homepage. And now I will ask Ellen if there are any questions that either Dr. Vlahakis or I can answer as it pertains to the Innovation Challenge projects.
Mary, I'm not seeing any questions at this time.
I'm going to take it back to you, Ellen. We've got about 10 minutes left. I would like to know if there are any questions.
Mary, we do have one question, and it says, can a medical assistant or a nurse do the screening?
That is a great question. And if you go out to that resource, the first one listed, the Depression Screening Fact Sheet, it does tell you that the test can be rendered or given, the screening, by personnel in the office, but it needs to be a provider level that interprets results. So what does that mean? That means if there is a negative result, there needs to be a note in the record by the provider level. The one that's submitting the claim, not the MA, of course. The MA is not enumerated. They're not enrolled. They can't submit the claim, but it would be expected that the provider that they're working under, the one that's submitting the claim for depression screening, would make a note of that negative result within the record. Of course, if the results are positive, then there will be additional decision making made as to whether or not, or whether, how to proceed with treatment and so on and so forth after the positive results for the screening. Dr. Vlahakis, do you have anything to add to that?
No, except that I thought it was an excellent question. One of the things that Mary and I talk about a lot is that proof of thought that we like to have from the providers, some evidence, some documentation that the provider has seen the screening, reflected upon it, even if it's in a very short time frame, and determined what to do about it. So in very much the same way, you would never obtain an EKG, for example, and then not comment upon it, not read it. I submit that depression screening results are equally as important, mental health being health after all. So that's my 2 cents, Mary. Thanks for giving me an opportunity.
I appreciate your explanation as well. Are there any other questions, Ellen?
Mary, we don't have any additional questions at this time.
Thank you, Ellen. Thanks for your help today. Our greatest compliment is when our learners recommend WPS GHA education to others, whether it's shared internally within your own organization or shared outside of your office or organization. Please consider recommending our education to others. This will help us reach our goal to provide needed education to all providers in our MAC jurisdictions. At this time, I'd like to thank you for your participation. This does conclude our webinar today, and you may now exit the webinar. Thanks, everyone. Have a wonderful day.